a fundamental question with any treatment. We should be asking ourselves, what are we trying to achieve with this treatment? Because if we're not clear on what we're trying to achieve, then we'll never know whether we're achieving it or not.
Hello and welcome to GP's Talk Cancer, brought to you by Gateway C. I'm Dr. Rebecca Leon and I'm joined by Dr. Sarah Taylor. We're both practicing GPs and GP leads for Gateway C. And in this podcast, we share our clinical experiences, reflections and practical insights to support earlier and more confident cancer diagnoses in primary care. Before we begin, a quick reminder. Although anyone might find this podcast interesting, it is designed for primary care health professionals. All patient cases are based on real clinical experiences, but are fully anonymised with no identifiable information. Gateway C is a free early cancer diagnosis resource funded by the NHS and based at the Christie NHS Foundation Trust. Today, we'll be sitting down with Professor Matt Makin. Matt is a consultant in palliative care medicine. Welcome,
Nikki.
Nice to have you in our fairly new studio.
Absolutely. Yeah. Can I ask you how you chose palliative medicine as a career?
That's a really good question, Sarah, to start off with. And I think my earliest memories were being on a urology ward at Dudley Road Hospital, which I'm sure you will know.
Yes.
And I remember one ward round, us pushing the notes trolley past a room where a man was in the room dying of prostate cancer and clearly in a lot of pain. And we didn't go in the room to see him.
Right.
And I remember feeling a bit kind of powerless about what to do. And then I think roughly at the same time, there was an article in the BMJ called Palliative Medicine, a New Specialty. And I thought, that's the one for me.
Interesting. I think my interest in cancer was when I was also at Dudley Road Hospital and worked at St Chad's. So my job was split onto the oncology unit there, and we covered some of we looked after medical patients and oncology patients, which is quite a new thing. So
and a very tough job at St Chad's.
Yeah, what an inspirational hospital. And it's not there anymore because we were talking to a consultant recently and it's been knocked down.
I remember that it had a very, very long corridor and it had a very good doctor's mess.
Yes, it did, didn't it? With iced coffee.
Yeah. And are you happy to still be practicing in palliative medicine all these years later?
Yeah, so I went into specialist training in the 90s, did my first palliative medicine job in 1995 at the Queen Elizabeth Hospital and then in a hospice in the north of Birmingham. And that was 31 years ago. I'm saying it out loud, 31 years ago. So I don't do as much clinical work now because I do clinical leadership role, but I still practice in the Manchester hospitals and also at the Christie as well.
Fab. So this is actually a palliative care plus, isn't it?
It is, we like to do. Yes.
So Sarah and Matt spoke in was it our first or second series?
Second series.
But we've invited you back.
Thank you very much. It's good to be back.
And I think the other thing that's quite interesting about this one is we have reached out to our primary care networks, asking them questions, what they would like to ask a palliative care consultant. So this is something we've put together and hopefully it will be what we've learned in the previous podcast. And we're going to build on it.
And we're not going to be, we're going to do a little bit about symptom management. We're not going to be doing much about pain because we talked about that in the first podcast. And there is quite a lot just generally of other stuff to talk about.
Yeah.
We just talked about how quite a long time ago how things have changed since oncology and palliative care in the 90s. But even in the last 10 years, what have you noticed that particularly for cancer patients has altered palliative care?
Well, I think the advances in research and the advances in our understanding about cancer at a molecular and a genetic level has led to much more targeted therapies, advances in radiotherapy, advances in surgery. We're now seeing patients even with advanced stage cancer, living a lot longer. That's changed enormously since we were doing our first oncology jobs in the 1990s, when patients with metastatic cancer, the expectation was that they would probably deteriorate quite quickly. We're seeing patients now live with metastatic cancer very much like we see people live with other chronic illnesses.
And does that impact then on, presuming that, because one of the things we've looked at things in the past when I've looked at the practice at our gold standards framework patients and our deaths and who's been on the gold standard framework, we've always found that our cancer patients we were quite good at looking at, and but the COPD and heart failure and frail patients were more difficult because prognostication was more difficult. Presumably these changes are now altering prognostication in cancer.
Yeah, to an extent, I think we're seeing. Many more patients having a flatter plateau, and then essentially falling off a cliff, sharp declines.
Right,
so flatter plateaus, sharp declines in cancer.
So it's still easier to recognise than some of the other.
I think it is. So I know that certainly caring for patients with other chronic illnesses, COPD, heart failure, some of the neurological conditions. What you can see is relapsing, remitting cycles.
Yes,
where people enter into a phase of multiple hospital admissions, and then that last admission is the terminal admission. And I think, Sarah, Rebecca, I think this is where we need to get better around end-of-life care, because for too many patients, their last months, their last weeks, time is spent, and time is their most precious asset. Time is spent with multiple hospital admissions where the goal of care during that admission is sometimes unclear, and then they can end up dying in a place where they don't want to be.
So just talking about being proactive rather than reactive. So that's why it's important we talk about advanced care planning, making sure patients are almost on the same page in the family that you are. And I know in your first podcast you talked about where they're at.
Yes,
and something that
talked about the CAM gap.
Yeah. And you've quoted that a lot, Sarah, about not pushing them down the stairs, but actually leading them down. And it's a good visual. In cancer care, it is changing. But what are the common patterns of decline that we should sit up and think actually somebody is approaching the end of life?
So, if I speak generally, and certainly in cancer, one of the things I'd always want to understand is where is that patient's oncologist at? So are there more options planned in terms of more systemic anti-cancer therapy, more targeted therapies planned for that patient? Is there any more treatment planned? I guess the other things that we'd be thinking of is functional decline and frailty, the need for additional care. And the other thing that we can see in patients who are approaching the end of their life is in some ways a snowballing of symptoms. So that sense of collecting problems where we fix one, whether it be an aspiration pneumonia, another one pops up, a urinary tract infection, another one pops up.
I just interrupt you there, Matt. I like that again, that vision of a snowball going down and collecting more and more and more snow as it goes down. So, I was going to say, Matt, your brain is that you actually picture in words, isn't it?
I do. I think in pictures.
You think in pictures, you do. If you had to walk around Matt's brain, it would be like lots of flowery stuff in pictures. But I like that, snowballing.
Yeah. And can I just check then? So you were talking about new lines of treatments. One of my recurring issues is people who are offered the potential for new lines of treatment. We possibly talked about this last time, when if they get stronger.
We did. And we've got to do better at that, haven't we?
Yes.
But also what we can't do is assume that what is necessarily reported is what is absolutely said.
Absolutely.
And by that, I don't in any way diminish the patient's story or invalidate what patients are saying to us. But I think that, and there's been some research in this, actually what people remember most about a consultation is how it made them feel. And then that can affect their interpretation of the consultation. Yeah. So it's really important that we see the letters. But I think as professionals working in secondary care, we need to make sure that we essentially reassess our relationship with the concept of hope.
Yeah.
So I think sometimes we think we're doing the right thing by saying, well, you're not well enough for treatment now, but if you get stronger, we could reconsider it. It's a tricky one because in some situations it's the right thing to do.
Yeah.
But in other patients, particularly where it's clear there's an inevitable decline, where we've seen that increasing frailty, that snowballing of symptoms, what it can lead is to those very difficult situations, which again we talked about at the last podcast, where there's this then frantic attempt by the family and the patient to become stronger. Which can be really tricky.
And almost the force feeding, getting stronger.
What we should also try and facilitate, and this is it's bigger than just what we're doing, is, and we love advice and guidance, don't we? Advice and guidance.
Oh, absolutely.
So actually, if I'm struggling with a patient who's being treated for ovarian cancer and I can't quite tell from the letters what is intended, that I can just email the consultant or the team and say, this is causing an issue. Can you give me some advice on how to deal with this family? Because you've probably seen them as much or more than we've seen them, and we need to know how to frame the conversation.
We need to be on the same page as well.
We do, yeah.
There's no point. The patient's telling us one thing, the oncologist means another.
Yeah, and we all need to understand.
Yeah. So going on from that, it's from people who are hardly able to lift their head up from the pillow, but they're still wanting more treatment. And unfortunately, we do see it in secondary and tertiary care that they are offered more treatment, particularly if the patient that, yes, I know it's going to make me more ill, but I want to have a go, which you can understand. Yeah. So how do we, or how do you advise about stopping treatment, when to and how to?
Gosh. So, it comes with a health warning in that I'm not an oncologist.
Yeah, okay.
And so I think I defer to my colleagues on oncology who do that really, have those really difficult conversations. And I think there's two things, isn't there? So I think first of all, I'm returning to that concept of hope and recalibrating hope. The opposite of hope is hopelessness.
Yeah.
And none of us want to be in a situation where we leave our patients hopeless.
Yeah.
But sometimes we have to reframe hope as we change direction, and focus on what matters to the patient, listen to what matters to the patient. But I think the conversations about, treatment decision conversations, it's been approached in different ways in different health systems. And Sarah and I were talking earlier about the BRAN model. And I thought we were going to go on to talk about laxatives, but that wasn't the case.
No, because we did laxatives last time.
It was how we frame a conversation that empowers patients. And the BRAN model, so BRAN, which is part and parcel of the sort of value-based healthcare movement, is a way of supporting patients to have informed conversations with their clinician about what are the benefits? What are the benefits of this treatment? What would be the benefits of having more treatment? What are the risks of having more treatment? What are the alternatives? Are there any alternatives to the treatment? And N, if we're going to do nothing, what will happen if we do nothing? And I think that really frames a conversation well. because there is also a perception, which in part I think we as clinicians are responsible for, which is more medicine means better medicine and better outcomes. And that's not necessarily the case. I mean, there have been clinical studies. There was a really good one in the New England Journal of Medicine, which compared a cohort of patients who had lung cancer. One arm had palliative care, the other arm had further chemotherapy, and the arm that had palliative care actually did better in terms of survival.
Yeah. I mean, I just want to use this as a personal case. So my father won't mind me telling the story. He was diagnosed with a melanoma probably 3 or 4 years ago, and it was surgically removed. And he had a follow-up conversation with one of the oncologists to talk about further treatment, and it would be immunotherapy. And actually, the oncologist must have learnt the BRAN method, because very much said, we could give you immunotherapy. You are in your 80s, you're a fit 80-year-old. However, the likelihood of you getting any side effects will probably be more risky than keeping you under active surveillance for the melanoma. So they agreed to do nothing.
Yeah.
And actually, touch wood, he's doing very well.
Yeah.
But a lot of people would have rushed into, I want more preventative treatment. And that was actually by the BRAN method.
Yeah, I think it's really good, because actually I think the other difficulty that we have is that when, a long time ago, chemotherapy was a 3-weekly thing, wasn't it? You went into the big hospital to have your chemotherapy. You had it every 3 weeks. At some point, you became too poorly to have it, and therefore you stopped going. Whereas now, a lot of the treatments are tablets.
Absolutely.
And I don't think, because, I've had a real drive at my practice to get all of these things recorded in the hospital medication section of our medication screen, so we know people are on it. But I would never think about stopping it, because I don't sort of feel it's my role, although I probably could stop it. But I think that people don't necessarily think about stopping these treatments that you're still taking, but they might have side effects or risk of side effects that would be, the patient would be better off. So if the immunotherapy stopped working, and we know that it's got lots of side effects of pneumonitis, gastroenteritis, all sorts of other things, itises, we probably should be stopping it.
Yeah, because the question I was going to ask as well, which Sarah is saying, is almost when that person is turning a corner and things are changing, and we see that they're on this potential oral chemotherapy, but also the other preventative drugs like the statins and the other things.
Yeah.
I think as primary care, and this was one of the questions that we had from one of our networks, is people are not confident about knowing when to stop these medications. So have you got any advice on how we reduce optimized medication?
I think the most sensible thing I've heard on this matter is relates to that question, that fundamental question of, with any treatment, we should be asking ourselves, what are we trying to achieve with this treatment? Because if we're not clear on what we're trying to achieve, then we'll never know whether we're achieving it or not. So I think there is a fundamental question on particularly medicines that are associated with risk reduction. Is that risk reduction relevant if, let's say, somebody's on a gold standard framework and we're measuring prognosis in terms of weeks or many weeks or even days? The important thing is that we're able to reassure people that we're not going to deprive them of treatment that they benefit from. Because I think the fear from many people when the P word is mentioned, palliative care, is that everything will stop. It's all or nothing. And I think reframing it around what are we trying to achieve with this medication, and is it relevant to this individual patient's circumstance? So again, it's back to that question of holistic assessment and using your judgment to turn that into the right conversations with the patient.
Because, not to be offensive, Matt, palliative care on the streets is people don't really want to see you. They think you're going to become dressed as a...
It's not just palliative care, believe me.
And actually, if we can educate patients what palliative care is all about, and that it's not something that we're just going to pull the plug out. There's lots of things.
Oh, absolutely, and
So you're almost for us in primary care as well, and I mean we've just had somebody on about who is involved quite a lot in social media, and actually changing what palliative care is. It does not mean that it can actually be helpful as well. So it's for us to educate patients as well about getting palliative care involved early.
It's trying to tell one of my colleagues the difference between the palliative care and the end of life care.
Absolutely.
I'm sure she's been retired for a few years now, and I still am not convinced that I got the message across properly. But I suspect that's one that you're doing more frequently.
Yeah, I think so, and I'm perhaps more making sense of that in the later stages of my career. I think when I first started as a palliative care clinician, I think my focus was very much on symptom control, and in some ways I think I was a bit of a symptomatologist. I could, I would give advice about treating symptoms, and I think at the time I was pretty good at it. I think what I paid insufficient attention to, and we're beginning to do more of that now, which I think is the right thing, is to have a bit more of a sort of a public health lens on palliative care and end-of-life care. And certainly I think, a lot of health systems across the country, we need to be asking that question. Are we getting end-of-life care right? Have we got the systems in place that assist, colleagues like yourselves in general practice that are able to, using the advanced computing we've got, using all the data we've got, population health data, SNOMED data, to give you a sense of which of your patients are at real risk of dying soon, and that the computer can give you the names, and then your clinical judgment turns those names into the right care plan for that patient.
So if we've got a list of medication, just thinking through it, and so you've got a patient who's on a statin, that's a sort of risk reduction.
That's great.
Yeah. But there'll be some of the medications that they're on that their need and the potential side effects will change as they become more unwell as well.
Blood pressure medication.
Blood pressure, I'm thinking, and anti-diabetic medication, I'm thinking as well, possibly. So I think there's as well as the stopping things, there's a whole load of things, aren't there, that you almost need to go through and say, right, the omeprazole, well, it might be helping there. It might be helping something, but it might be but we might need to go through each thing and say, this is likely to cause you more side effects. This is for a risk that really probably we don't need to be concerned about now. And this is possibly helping you, rather than saying, we're stopping everything.
So I've worked quite closely with my in-house pharmacists. And I think they're really helpful for doing that, going through each one, talking about the pros and cons. So you're talking about the blood pressure medication. I'm thinking about something like lansoprazole. Yeah. By stopping that, actually people get quite a lot of rebound gastritis with it. So you can change it to an oral dispersible, because one of the other things we need to think about is where it might be taken out of our hands because the patient's oral route might suddenly stop.
Oh, absolutely.
Yeah,
and that creates a new, I think that creates a new challenge, which is thinking about which of the patient's medication might they have withdrawal symptoms from.
Yes, because we were talking about
gabapentinoids.
Yes.
And so, we have some patients who have been on gabapentinoids for a long length of time, for chronic pain, for pain maybe associated with their disease. And if those are stopped abruptly, they can lead to a very unpleasant withdrawal agitation syndrome. So as well as thinking what drugs does this patient not necessarily need, and, I think our elderly care physicians are really good at that sort of pruning drugs, but also what drugs might the patient withdraw from if the oral route was not possible. Yeah. So are they on anticonvulsants? Are they on gabapentinoids? Are they on
antidepressants?
Antidepressants, exactly, yes.
Yeah, it's a really good point. So what do you do? I mean, I wouldn't want to stop somebody's sertraline because
They're on 200 milligrams.
but if they're on 200 milligrams, do we need to start thinking about dose reducing? What would be your advice?
Yeah. So again, a really good question, and I think there are some circumstances where I've sought advice from a psychiatrist. So you'll have patients who will be on some quite complex treatment regimes, and then is really important to have those treatment decisions in partnership.
Yeah.
I think sometimes you don't get the chance to do that.
Yeah.
And certainly in the context of a patient who is dying and we're anticipating that they're going to have a withdrawal reaction, which might then feed into a sort of a terminal delirium or an agitated delirium near the end of life. I'm thinking about things, is somebody withdrawing from nicotine? Do they need a nicotine patch on? Is somebody withdrawing from alcohol? Is somebody withdrawing from antidepressants or gabapentinoids? I think that's where anticipatory prescribing needs to have a lot more judgment to it.
Yeah.
So I'd be using maybe small doses of midazolam in either as required, but probably also in a syringe driver to manage the restless agitation sometimes associated with withdrawal.
I suppose it comes back to what we started off with on the medication. It's a personalised approach to
Absolutely.
each and every medication, really, isn't it?
Absolutely.
And I think we're probably not quite there with doing that.
It's having the confidence of going through it. And actually, I have a colleague that I work with in general practice who is very good at frailty and nursing homes, and he feels very confident crossing out.
Yeah.
I've got other colleagues who just are frightened if they miss a statin dose. So it's about confidence, about conversations like this. The other question I wanted to ask was about steroids. So with a lot of our patients, they may be on steroids for multiple reasons.
Yeah.
What do we do when they can't have it via the oral
And when would you
steroids?
use them? Yes, that's a difficult one.
So when do you...
So you steroids or...
Yeah.
Okay.
Tell us everything you know about steroids.
Go. Okay. Well, I think the first thing to say is steroids are drugs that have to be treated with the utmost respect.
Yeah.
They're extremely potent. Okay, they're extremely potent. They can be really beneficial, but they've got side effects that can really be problematic.
Yeah.
And I'm talking from steroid-induced psychosis, and I've cared for patients who have had a steroid-induced psychosis, and that's really scary for the patient, for the family, for staff. I've also seen many, many patients who have been started with good intention on 2 milligrams, 4 milligrams to give you a bit of a tonic, a bit of a boost your appetite, a couple of milligrams of dexamethasone, and then 3 months down the line find that they actually can't get out of a chair because they've got such a severe proximal myopathy.
Yeah.
And they're symptomatic from the hyperglycemia, the steroid-induced diabetes that occurs in about 10 to 20% of patients that we've not picked up. That they can't eat their lunch because they've got such florid oral candidiasis. So you've got to treat steroids with respect. They can be an absolute lifesaver in some severe symptoms. Nausea, a patient with liver metastases who's got nausea, a patient with severe hepatic capsular stretch pain.
Yeah.
With judicious use of steroids, you can almost switch that pain off really quickly. And also with using it for neuropathic pain, nerve-related pain. So steroids are really useful. Steroids are useful in managing the symptoms of subacute bowel obstruction. They're useful for managing the headaches and some of the neurological features of brain tumour, for reducing the risk of fits. But the approach has got to be that question of who is the responsible clinician, who is holding the ring for the prescribing, because we can't be in a situation where everybody has a go. If you start it, you're responsible for monitoring it.
Yeah.
I think that's interesting, isn't it? Because I think that becomes a real issue with some of our end-of-life patients where we have multiple teams going in, which is great because our Macmillan team and our district nursing team are fantastic and really, really important parts. But I think that does sometimes, and then if you've got a palliative care consultant going in as well with the Macmillan teams and you've got an oncology team involved, I think that ownership of some of those decisions gets lost.
You don't know who's almost leading from the front.
Yeah.
I think you've just got to call it out. Who's leading the prescribing here?
Yeah.
And I always saw my role as a palliative care physician as supporting and
Advisory,
advising.
yeah.
This is not, I think where we go wrong sometimes is in the community or to a certain extent in the hospital setting is that we wrap our arms around people because it feels good to do that and say that they're ours. We're there to advise and support. A brief story. You can edit it out. I don't know. So on my first day as a consultant in palliative medicine, I turned up to work with my suit and my briefcase, and I was given a bleep, and my bleep went off. And I answered
You actually turned up to work with a briefcase?
Yes, I did. Yeah, I did. It had.
How do you not know?
It had my sandwiches and it was
Stethoscope?
a stethoscope
Round his neck, probably.
and a notepad. And it was in my briefcase and a notepad. And my bleep went off, and it was a GP from Llangollen. And I'm not going to do his accent. Dr. Rhys Davies, wonderful man. And he said, "Hello, are you Dr. Makin, the new palliative medicine consultant?" And I said, "Yes, I am." He said, "I'm ringing to ask how I make sure none of my patients are ever referred to you." And so I went which was a bit of a shock at the time, but I actually went to see Rhys and we sat down together and he talked about what a pride he took in his district. He had a wonderful team of district nurses took in end-of-life care. And what he didn't like is people dabbling in that. He actually then came to work with the Palliative Care Service as a GP Macmillan facilitator, and he did some groundbreaking work on anticipatory prescribing and in acknowledging that most emergencies happen out of hours and setting up systems to support
absolutely,
people.
yeah.
So that's a little sidetrack.
I like that.
Yeah, it's good. Yes, absolutely. So we covered the first part of it. It feels like Dr. Kendall Pharmacology Roadshow.
Oh, yes. Gosh. I'm getting a bit of PTSD thinking about
I
that.
know. There's where we had these pharmacology lectures where you had to, a few people from the year were chosen to go and go at the front and answer all the questions on a particular drug, and it was always very stressful when it was your turn and who had to do it, and I feel like our grilling of Matt is a little bit like one of those. So we haven't come on to the stopping them because we've come on to the use. How, presumably, because we can't give those via syringe drivers either.
Steroids.
Or can we give some?
Yeah, you can. And you give steroids. So you've got to get the maths right. So
There's a conversion.
yeah, 3.3 milligrams. Well, follow your local guidance. Is what I would say. That's my safety net advice on this because it does vary in some places. Follow your local guidance. But 4 milligrams of oral dexamethasone is about 3.3.
So we wouldn't want to be stopping somebody who'd been on.
So individualised because it depends how much they've been on and for how long.
Yeah.
So if somebody's been on, 2 milligrams for their appetite for 5 days, and then
that's
that's a different story.
Yeah.
If somebody's has been on 8 milligrams of dexamethasone because of a primary cerebral tumour to manage symptoms of headache and manage fits, I'd be really reluctant to stop that abruptly because we've got one chance to get this right.
Yeah.
That end of life care, we've got one chance to get it right. And what we don't want is for a situation for somebody's last days or hours to be characterised by uncontrollable fits or headaches or anything like that.
No, I think lots of symptoms are quite difficult, but I think fitting it is a really difficult thing for people to watch, isn't it? I think people cope with patients who are comatose and not responding, but somebody who's fitting, I think, is a really difficult one to. So, yeah, I agree. Avoid at all costs. We've talked a little bit. I'm just looking at what we agreed to talk about. We local services. You talked about this briefly.
So, local services, we know it can vary across the country. Would you agree, Matt? Just say yes.
I always agree with you.
There's our mission.
Thank goodness.
Yeah. Well, locals. Look.
There's our mission as GPs and primary care to almost know what our local services are.
So there is, I think there's a way of reframing this, isn't there? That actually, so one of the things we've talked about is the importance of getting supportive care right through cancer treatment, managing people's symptoms through their treatment, to get the palliative care right in terms of the holistic assessment, support, and acknowledging what matters to the patient and family. But the other bit where I think we've really nationally got to say we've got to get this right is end-of-life care. So that sense of what are the crucial ingredients to get end-of-life care right, and I think some of that is related to services that maybe sit outside the palliative care team zone.
Yeah.
So again, back to this is a lot of reminiscing here, but back to my consultant interview 30 years ago, and I was asked, what's the one thing that would significantly improve palliative care for the patients of this area? And I said the 24-hour district nursing service.
Absolutely.
I think district nurses are key to they're a core component of delivering good end-of-life care. So that, district nursing, hands-on care services and the ability for a rapid response in a crisis, and also the ability to access specialist advice without delay back to that advice and guidance.
Yeah, and I think that's all. And I think and actually when we've had patients, it'd be the same for you, Rebecca, when you have patients that you look after at home, where you've got the district nurses involved early on, they know the family, the Macmillan nurse is going in and can access support from a palliative care consultant as well. And obviously the Macmillan nurses have a huge amount of expertise. Things can go very well, and families are so grateful when things go well. And sometimes some situations are much more difficult than others. I've had one patient who lived alone, had no family, who we managed to look after and died at home, which was quite something. And that was just because of fantastic services. But then I had another patient whose daughter stole her end-of-life drugs. She had a daughter who was an addict and stole her end-of-life drugs. That's a whole new list of problems that you've got to start thinking about. But yeah, you're right, that those services, and I think they will differ slightly across the country. But district nursing provision is...
shout out to my district nurses.
Brilliant.
So they'll often guide me. So you're talking about your patient's daughter who stole the drugs, and they very much will give us a background of their social situation.
Yeah.
Health inequalities in palliative care is huge.
It is huge, yeah.
And
well, it's no accident that hospices spring up in leafy suburbs.
Yeah.
Because that's where the fundraising muscle is.
Yeah.
We're in the, I consider Manchester to be the second city in the country. Sorry, Birmingham. But there's not a hospice within the city. Within the city of Manchester, there are hospices within Greater Manchester, but there's not a hospice within
in the area
city
that you work in, North Manchester, there's no hospice?
Not within the boundaries of the city of Manchester. Yeah. There are hospices there's a hospice in Bury,
yeah.
there's in Oldham and Rochdale. But within North Manchester or within the centre of the city, no, there isn't. Hospices generally are situated where the fundraising muscle is.
And then you add in the problem that the patients who have some of the greatest need and the lowest incomes have to travel to these places, which is a huge issue, isn't it? Because
really
thinking about the actual the hospice that's in Stockport, which is very close to us. Bus routes to get there, I suspect they're almost non-existent.
Yeah, it's inverse care in action.
It totally, yes.
It is, and that's right. So you asked earlier about variation in services. there is variation in services. I think what we've got to be very clear is what are the core services we need to support end-of-life care in the community. Because the other thing that worries me, Sarah, is that we don't, and I'm choosing my words carefully, but we don't risk sacrificing people on the altar of home care. That we say, people, we must do a left shift. People have got to die at home and not in hospital. And actually, some people
definitely
it's the right place for them to be in hospital. The patient who has known that, let's say, known the team on the haematology ward, knows, trusts, has got difficult symptoms towards the end of life. So I think if getting end-of-life care right in terms of the core district nursing function, availability of medicines, syringe drivers, advice, specialist advice where needed, etc. We've got to get that right.
The district nurses also will often lead the advanced care planning conversation as well.
Yeah.
So when we're talking about DNA CPR, when we're talking about preferred place of care, preferred place of death, as you were saying, if they say, I only want to die at home, or I only want to die away from home, it's exploring those. So if there's somebody who's living very isolated, no family nearby, it may be not in their best interest to be looked after and die at home. So there's conversations about nursing homes and about other places that they
and also
can
I think it's recognising that people's decisions changed.
Oh, absolutely.
So I think that, so I just know when my husband and my mother-in-law were looking after my father-in-law, it was only about a week and they were both exhausted. And actually, and there's a limit to how long families who are working can
absolutely
go on rotation. So I think that things change and as disease and illness progresses.
And that's why that power of review is really important, isn't it? That relationship and that power of review. And one of the things that you mentioned there, Rebecca, was those conversations and the importance of actually having those conversations and revisiting those conversations and how you visit those conversations. So that they're done in a way which is compassionate and is a gentle conversation. I think framed around the fact, if time was short, what matters to you?
Yeah.
What's important to you?
Yeah.
And being able to then revisit that, has that changed?
And some of that, again, will depend on, I suppose, if the nearest hospital, when we were talking to colleagues in Scotland yesterday, if the nearest hospital is a 5-hour ferry journey away, then the conversation changes. If it's an hour bus ride away, the conversation probably changes. If it's a 5-minute drive away and you've got a car, again, it's a different conversation, isn't it? It's a very individualised.
Because when we did talk to our Scottish colleague yesterday, and it brought up rurality as almost a health inequality, we learnt yesterday that it was another part of our jigsaw puzzle when we're thinking about what's in the best interest of the patient.
Yes.
So we add in the symptoms and the examination findings and the risk factors and the family history. And now if we add in how many hours on the ferry, that will add in something else. So we've decided...
So it's a public transport.
Yes.
I think, some of... There are patients living in deprived areas who don't have access because actually they can't afford.
They can't afford to.
Yeah. And if you haven't,
and choices. So they have money. Do they spend it on a place to stay overnight, or do they get a bus to their mammogram? We got yesterday.
Yeah, or a bus to visit people.
Yeah.
If you're not going to have many visitors in hospital because nobody can afford to come and see you, that is.
So individualised care. I think that's a good point.
So I think we said we would talk a little bit about a bit of symptom control, didn't we?
So we're really getting into the Dr. Kendall Roadshow stuff.
We are now, yes.
Yes. This is the proper stuff.
I think we said what we would particularly focus on because it is nausea as a symptom, because we talked about pain last time.
And bowels.
Well,
a bit.
I think it's difficult to do a podcast with Matt and not talk about bowels, actually, because last time he was telling. I remember one of my take home was that anybody who prescribes lactulose should taste it first.
Yeah.
And anybody who prescribes an opiate should take full responsibility for their patient's bowels.
Yes.
And so you see,
and similar thing to steroids. If you noticed, I got a bit agitated about the steroids.
And the other thing you learnt, because again, you could hear that I wasn't on this podcast, but you've not stopped talking about it, both of you, is the saying Keppra.
Yes. Yeah, go on.
Oh,
Symptom.
That's it. So it was very effective anticonvulsant. It can be given in the syringe driver, and the best way to pronounce it is to think of the tune Nelly the Elephant. And if you say levetiracetam to the tune of Nelly the Elephant, you'll always say it correctly.
And you won't bother.
Levetiracetam.
And you'll be above levetiracetam.
Yeah.
I was doing it right.
Yeah.
Never did it before in my life.
There you go.
I think I'm still stuck to Capra. There we go. Okay. So you want to talk about nausea and vomiting?
Yes.
So that's one of them.
Yeah.
So go.
Go.
So let's talk about it.
Everything you know.
Listen, let's start with, let's be doctors. Let's take a history. Let's listen to the story. Because I'm a strong believer that if you listen to the patients, they'll give you the diagnosis. And when it comes to nausea and vomiting, like most things, and you know, you guys are really good at this, that pattern recognition. And there are certain patterns of nausea and vomiting that will give you a clue to the cause of the nausea and vomiting. And, you know, you can follow that up with a clinical examination. But if you treat on the basis of understanding the probable cause of the nausea and vomiting, the likelihood is you're only going to need one drug. I think where we get into problems is when we're on a cancer podcast, GPs Talk Cancer, and I use the phrase before with pain, but we've got to see through the cancer fog. So we've got to say, actually, so this patient has got nausea, okay? What does the patient's individual circumstances and what clues does the story give us about the cause of the nausea and the vomiting? Because it could be that it's related to their medication. They might have started on opioids. They might be very constipated. Are they at high risk of hypercalcemia? Do we know that they're in renal failure? Have they got liver metastases? Is there a sort of a chemical sense to the nausea? Are they on systemic anti-cancer therapy that may be associated with nausea? So is there a cause that's setting off the body's smoke alarm? Okay. And the body's smoke alarm is the chemotactic trigger zone. We are really getting into
Proper
pharmacology here. Yeah, people will be ringing in at you now, are they? And which sits outside the blood-brain barrier, and just by the fourth ventricle is picking up that sort of those signals in the blood that something's not right. Or is it that the gut receptors, the vagus system, is picking up something going wrong in the gut?
Yeah.
And that's triggering things. Or is it a vestibular? Is it a balancing that could be affecting it? I've had patients where we've really searched around for the cause of why they're feeling nauseous and sick, and it's turned out it's been a sort of a pharyngeal stimulation. They've had either, you know, really severe pharyngeal thrush, or they've had, you know, an NG tube down, which is just constantly tickling their pharynx and making them feel sick. The one I think we underestimate, though, is the higher center causes for nausea. And we often say sometimes, don't we, that people can become sick with worry. I'm sick with worry. And we underestimate that the sense of the situation that that anxiety and stress can cause a sort of low level sort of nausea. So we've got to explore that. I guess the one thing I would say, though, is that if somebody's hypercalcemic, no matter how many antiemetics you throw at them, you're not going to sort it. So the other important thing is try to get to the root of the cause, and if you can correct the underlying cause, that's the best treatment.
So once you thought about it, so taking bloods in end-of-life patients is quite a difficult one, isn't it? Because you don't want to pick up things that you aren't going to do anything about, but you do want to be able to treat reversible causes. So there's a little bit of me thinking, Do I need to know that somebody's EGFR has fallen from 40 to 20? No. But do I need to know that they're hypercalcemic? Yes, because I can do something about that.
Hyponatremic.
I think there's just bits of being able to, I suppose it's like we're talking about with virtually everything we've spoken about today. It's that individualising, isn't it? Just going, actually, okay, they are anemic and that's relevant and we can do something about it because they might benefit from a transfusion, they might benefit from some iron tablet, whatever, or they've got something irreversible like hypercalcemia. But we aren't going to get overly worried about a drop in renal function and keep checking it because it's going to keep on dropping.
Yeah. I agree with all of the above. It's about that individual assessment of the patient's circumstances and you turning your clinical judgment into care.
Yeah.
And there may be circumstances where the right thing to do may be to if you've got a pattern of symptoms, so you've got a patient who has become very thirsty, they look very dehydrated, they may have be reporting that they've had instances where they've even wet the bed, that they've had such a diuresis that's related to, that gives you a clue that this may be hypercalcemia.
Yeah.
And they're deteriorating it. That there may be that voice in your head thinking, is this hypercalcemia? Do I need to rule this out? And that might be informed by the trajectory of their decline. So that if actually they were up and around and functioning fairly well a week ago, but have developed a pattern of symptoms that you recognise, perfectly reasonable to use your judgment, and sometimes we don't get it right. Sometimes we get it wrong. But we use our judgment and clinical judgment. So important.
I think it's also important to be open and honest with the patient and the family. And one thing I suppose my strapline of being a GP is I don't want them to walk out the room thinking I'm keeping something from them.
Yeah.
So from that point of view, it would be almost like, I'm a bit concerned why you're still symptomatic. We've tried this and that. This is what I'm thinking. I'm thinking about a blood test. How do you feel? How do you feel about it?
So it's always BRAN stuff again. It's
all BRAN stuff.
What the benefits, what the risks, what the alternatives.
Be a little bit uncomfortable with a blood test, but actually it could make you feel a lot better. Yeah.
And there might be bits of it that we sort of, and then it's explaining the results and saying, well, yes, the
loads of reds.
Yeah, there are loads of reds, but because that's one of the issues, isn't it? That patients can see their results, but you need to be able to explain that some of it is acceptable and expected, and some of it is something we can do something about, and clarifying the difference between the two is quite important.
I think the great thing about, I was going to say the great thing about nausea and vomiting, there's very little that's great about nausea and vomiting.
No, there is very little.
It's the body's evacuation system. It's it's of course, we I talked about chemotactic trigger zone, the vagus, the vestibular, the higher centers. Where do all those things meet? In the vomiting center, which is in the brainstem, isn't it? And the vomiting center is the part of the brain that coordinates in an involuntary way, because your sense of nausea is, you have this sort of conscious sense of nausea, but vomiting is involuntary, and it's the brain coordinating that evacuation by taking deep breath, closing the esophagus, expelling everything.
So is nausea very much more about a warning sign, or is it to get your body ready for what's going to come?
A bit of both. A bit of both. That's why I've said the chemotactic trigger zone. I've likened that to the sort of the smoke detector. There's something going on. There's something wrong. We need to do something.
Okay.
The messages from the gut are the signal that we might have to evacuate folks. and
you're picturing if you want to walk around his brain, honestly, it's hilarious.
And then the other thing is actually then matching up the drug with the cause. So vestibular system.
I think the cause is
cyclizine.
just giving metoclopramide just without thinking.
Yeah, and it can be quite, and you have to be really, really thoughtful, don't you? Because, we've got patients with Parkinson's disease who can get nauseous. And we've got to remember that actually, well, if we give them haloperidol, which is a really good antiemetic at very low dose for those causes that trigger the chemotactic trigger zone because of all the dopamine associated mechanisms. But actually, we're not going to be giving haloperidol in Parkinson's disease. We're not going to be giving metoclopramide in Parkinson's disease. So there are other choices in this where the specialist advice is really helpful. But I guess two things, if I may, thank you, around nausea and vomiting. So I think it's early preparation for nausea and vomiting. I have a low threshold for using a syringe driver.
Yeah.
To get the drug in, using a syringe driver.
Makes sense. Particularly if you're not able to keep them.
Absolutely. So low threshold to use a syringe driver. And then I think the other thing is that I also have a low threshold for diagnosing people with akathisia who are on infusions of metoclopramide or are taking metoclopramide regularly. So that akathisia, that sense of fidgetiness, restlessness, wanting to get up and move around, often presents in a very subtle way with insomnia or just anxiety. And there have been a couple of instances over the past year where I've been talking to a patient who's on an infusion of metoclopramide for nausea, and they've described symptoms where I've thought, I think this might be akathisia, and that's led us to change.
If I could summarise, it's almost find the cause or the potential cause of what's causing it, and then by history, examination, listening to the patient, if further investigations need to take place, a bit like for hypercalcemia, then we could consider it. And almost just understand a bit of pharmacology and pharmacokinetics about what helps with what. Use our pharmacy technicians again. They're very, very good.
Advice.
And then, but if they've got comorbidities, you talk about Parkinson's, I'm thinking about patients with heart failure on.
Absolutely, yes.
Then actually you'll have to get your heads together with either other primary care colleagues or as palliative care, that's when I would ask for some advice, or their cardiologist.
That's a really good summary of that. Yeah, perfect.
I think we've had a fascinating talk, Matt. Thank you. We're going to do few key clinical points, and then we're going to do the word of the podcast, which is just something that encapsulates what we've learned today. I like that word, encapsulate. Yes. Okay, so a key clinical point, Matt. What would you like us, if we remember nothing else, give us something?
Well, I think I'd reflect on using the digital tools we have at the moment to identify patients who are at risk of dying within a year. And what I'd say is that these digital tools give us names, but our clinical judgment is what turns it into the right care.
Sarah?
I think I'll go back to what Matt mentioned in the last podcast about seeing through the cancer fog and evaluating individual symptoms and individual decisions on their own, taking the background into account, but just, individual evaluation.
And I'm going to talk about knowing what you have in your area, so knowing what local services are available, and using the wider community MDT team to the best of their knowledge and expertise.
Yeah,
great.
Because they have a lot.
Loads. So, Matt, we'll start with you again for word of the podcast.
Well, I'm quite clear on what that is. It's sashimi. And it's because I can't get out of my mind that big sort of tray of sashimi that you were eating before we came in, and the high risk soy sauce move that you made So I thought it was going to go sort of
It was
all over.
virus.
Either your blouse in my shirt.
Yeah, and then it was, and there was some talk that I didn't have chopsticks. So,
Okay, but it's probably a good thing you didn't have chopsticks.
but it was a very high protein lunch. Okay,
Yeah.
so
Is that the sort of thing you're looking for?
Because you know what?
It'll do.
Yeah.
So,
Fine.
Sarah, I'm going to go for BRAN again.
You're gonna go
Is that
BRAN,
yesterday because I like
Salmon and bran.
yeah.
do I need to do a food-based one? Oh gosh, you've completely turned me off here. Okay, I'm going to go for 3. You know me, I like to do holistic individualized care.
There you
Okay.
go.
I thought you were going to go for 3 as your word. I think, where's that come from? Yeah.
3, holistic individual. So it's working on your key point, but each patient needs their own individual care.
Absolutely.
Fantastic. Well, thank you, Matt, for joining us today. Thank you, Sarah, as ever.
Thank you.
I don't buy an eel
Thank you, Rebecca.
on the way home.
No, I'm not buying an eel or a live lobster. So thank you for listening to GP's Talk Cancer from Gateway C. You can access our CPD accredited modules anytime via our website, and all reference studies and guidelines for this episode are linked in the show notes. If you'd like to submit a question for any of our to-be recorded episodes, please make sure you sign up to our Gateway C mailing list. The link is in the show notes and you'll receive a survey link. Alternatively, please email your thoughts or questions to the christy.gatewayc@nhs.net. A big thank you to Matt and to our producers from Gateway C and Listening Dog Media. If you haven't already, please follow the podcast so new episodes drop straight into your feed. And if you think a colleague would find this episode helpful, we'd really appreciate you sharing it. It helps us reach more primary care health professionals. I would like to thank our primary care network for bringing in the questions
Really good questions.
and our conversation today.